long. So this is a discovery of association rules of the relationship between food consumption and lifestyle diseases. So the idea of this research, which is an ongoing research, we are doing that since about 5 or 6 years, is that we believe that, I mean, this is not something new. We knew that we have read a lot of, let's say, articles, or even though in newspapers and magazines, that a lot of relationship exists between, let's say, food consumption and the so-called lifestyle diseases. Then we have seen that these studies that have been conducted, they have always been conducted between doctors or clinics, and let's say a small part, the amount of patients, like for example 20 or 50 patients that have these lifestyle diseases. And our idea was looking at this with big data. So we just started, let's say, let me just speak about the lifestyle diseases at first. This lifestyle diseases, according to the WHO, is the cause of 79% deaths in developing countries. When we speak about developing countries, we just don't speak about, let's say, Western countries. We also speak about other countries that are in development, like, let's say, China, India, and other parts of the world. So these are also called non-communicable diseases, as opposed to communicable diseases, like, for example, corona or cholera or Ebola, which also contagious. As lifestyle diseases are also called chronical diseases. As we know, they are not contagious. So they should not be any quarantine or something, and we see it a lot, and it is a lot of diseases like obesity, hypertension, heart disease, diabetes, cholesterol, cancer, even though mental diseases are the so-called lifestyle diseases. And they are increasing rapidly in developed and developing countries, as I said. You see at the right-hand side, the risk and factors of these different chronic diseases. You see it in different countries or different part of the world. So this is a concern that actually concerns us, many of us in our countries, as we are going to be, let's say more than 50 years old or something, or even though less, like 40, we start to have these chronic diseases, one or many. And so we wanted to see if there is a link, which is also have been said, a lot of links between what we eat and how would you get these chronic diseases. Okay, so what is our data set? Our idea first was, that's why we conducted a preliminary study at 2015. This is the time where we started. We said, okay, just as a proof of concept, we are going to look at, we had, let's say, freely available data from a grocery store, food consumption in the West Coast. And then we also gathered statistical data about the health of these people on the West Coast, and then we linked them together, and we found some interesting rules about, let's say, the food consumption and, let's say, chronic diseases. So this was our proof of concept, and we said, okay, using data mining tools has a big potential. So we wanted to see if this is also valid in Switzerland. So this in Switzerland, the current study 2020, this 2022, I'm sorry, that is an error. You see, Switzerland is a small country and is comprised of in middle of Europe and comprised of 4 language regions and a population of about 8 to 9 million people. So we started to gather data from a Swiss Nutrition National Survey that was conducted in about 2016 or 17. And we also have acquired data from the Swiss, let's say, National Health Service, from the Ministry of Health. They start to gather every 5 years, so a big questionnaire about the health of the people. And each of these databases also had a demographic based data, which is important because we wanted to link these two databases together. So we needed demographic based data also to link these two databases together. So what we have done, we started to do the so-called knowledge discovery, which is based on the proposal of Fayed, which has worked in IBM. I think still works there, I'm not sure. So he has proposed a 5-step, let's say, of knowledge discovery process. So he said, first of all, select your data, and then you need a lot of pre-processing, and then you have to transform your data in the way that you want to do your data mining, which is the next step. And after the data mining, we need an expert. In this case, we have an expert, a dietitian expert, which has also interpreted our data, because we are from computer science part. So we did all this technical work, from gathering data to pre-processing to transforming and to data mining. But in order to understand what these rules mean, we have also acquired her knowledge. That's why also data mining is a so-called multidisciplinary field, because it needs from one side the data miners, the mostly programmers and computer scientists, but we need field expertise that is in different areas here in health or diet. We can have it also in other areas like insurance or banking, or even though in different areas. So we have selected our data, as I told you, menuCH. This was our Swiss nutrition data that was conducted for the people between 18 and 75 between 2014 and 2015. It was comprised of 2 surveys, one by phone and other by questionnaire. The questions included cooking, eating, drinking, and exercise habits. And we had also about body measurements, weight satisfaction, also the social structure of the interview, which also we used it for the demographic linking. And the phone survey, it was an additional survey that they called the people after the questionnaire was filled, in order to ask, let's say, additional questions about food preparation, if they are going to they eat it cold food or hot, or how many, let's say, meals per day or something like this. And then, as I told you, this demographic table, which was very helpful because it contains age, gender, marital status, and also nationality, because in Switzerland, we also have about 20% of the people are other nationalities. And also household size, like single person or family or a pair or other part of kind of, let's say, household types. Then we had the second database, which this so-called lifestyle disease database, we call it. As I told you, Swiss Ministry of Health gathers every 5 years data from around about 20,000 Swiss citizens. Again, they have a dual approach, like the menuCH. One is a questionnaire, and the other one is a phone interview. And because in Switzerland, privacy is very, very tight, you cannot ask the people, like we've gathered for the, let's say, our proof of concept study from United States, to ask them if they have, let's say, high cholesterol or high blood pressure or whatever. But you have to ask questions around these subjects in order to come to the conclusion of, let's say, how the people can have, let's say, blood pressure, or they have, let's say, diabetes or not, which I'm going to explain in the next slides. So we had data from 1992 to have about 20 years data. And then we have, as I told you, we had questions. We had to start with find which questions is related to which topic. Topic, what I say is which chronic disease. And this also we have done with our health experts, because as I said, we needed their expertise in order to understand the field, which is not our field. Our field is computer science, as I told you. So then with their help, we could reduce the questionnaire results to 9 subject areas, which is 9 chronic diseases like alcohol consumption, aging problems, disability, cholesterol, diabetes, and chronic diseases are the ones that we could not specify more, drug use, nutrition, and health status. So then after this, we started to, let's say, pre-process. This is a usual approach. When you are going to build your database, you're going to see if the redundancy is there, which you are going to eliminate, or you want to see if data is complete. If you can complete, you complete it, or you are going to, let's say, delete when you cannot complete it. And also the redundant data was deleted, and also when we have found some inconsistency in the data, so we also deleted it, or we were able to correct it with help of our health experts. Okay, so the second step was the pre-processing, and the third step was at the right-hand side, we had our menuCH data, which is about a nutrition database, and at the right-hand side, we had our health data, and we had to link them. So because here we had about 2,500, let's say, interviewees, nutrition part, and on the health part, we had about, as I told you, 21,500 each times. So it was about 5 times. It was about more than 120,000 people. So we had to link them, and we built as an additional table, which we call it a person profile. And there we have built groups, like gender and age groups and household size and marital status, and also language, because in Switzerland, as I told you, we have 4 official languages. The 4th one is spoken from about less than 0.5% of the people, so we didn't consider that. Also, we didn't have a lot of interviewees in this language. So with this person profile, we were able to link these 2 tables, these 2 databases together. And now we had to transform. Transform means that our tables from the chronic disease was very big, because there was a lot of questions. So we started to categorize let's say, chronic disease tables, meaning that we had to create categories for the chronic diseases. Like, for example, when we had alcohol tables, we said, okay, all the answers that are related to daily alcohol consumption up to 80 gram, or bigger than 80 to 23 grams, or bigger than 23 to 28 grams, because they are levels of alcoholism. And for that, we had to actually calculate, meaning that, for example, people didn't say, I'm drinking alcohol. They say, like, it was different questions, like, for example, how many beers do you drink a day? How many glass of wine or other alcoholic beverages do you drink? So we had that as an answer. And then we were calculating the answers to if it would be 18 between 0 to 18 grams, or bigger than 18 grams, and so on. So we did that. So that has hugely reduced our answers. So we had these categories. This is an example for alcohol. We had it also categories for other chronic diseases, which we could also use with the help of health experts. in order to further reduction our tables. So at the end of the day, we had this integrated database. You see at the right-hand side our health database, which is comprised of tables like chronic disease category. So our categories are there. So we had all the survey questions here and all the answers. I'm sorry. And then we had this demographic data table, as I told you. At the right-hand side, we had our menuCH, so our nutrition database. And you'll see here, this person profile is a linking table, which enables us to link this health data with the nutrition database. So between this proof of study and this study, we also did another study 2021, but we had at the right-hand side the menuCH. It was the same, the nutritional database, but the health database was not 20 years health database. It was just health database of 2012, and we found some findings. One of the important findings that we have used to further improve our rules for this study was that we find out that when we are, let's say, do not weight the attributes because of the, let's say, algorithm that we use, Apriori Algorithm, we see that these characteristics are going to be pruned out early because of the minimum support criterion of the algorithm. And so we find out that a weighting of the algorithm of the attributes could be useful in order not to prune this, let's say, these rules as soon as possible. The reason why this pruning happened is that Switzerland is a very kind of healthy country. So we saw later people that had chronic disease or showed a sign of chronic diseases. The majority of the interviewees that we had, they actually were healthy. But we were not interested, let's say, on the healthy people. We wanted to see the, let's say, more to highlight the unhealthy people or the people that had these chronic diseases. So we had to do this weighting in this algorithm in order to have more of these unhealthy people and see the rules that applies to them. Okay, so then this study, we went again to our health expert and we said, okay, we have these categories: physical activity, dietary supplements, salt intake, smoking, and beverages. And based on pair knowledge, we could weight these categories. Like you see the final here, you see a subcategories weighting, because she said, okay, physical activity could be seldom or irregularly or regularly, or we by dietary supplements we can have different variations. At the end of the day, you see that she weighted physical activity for the chronic disease as 30%, and then dietary supplements about 3%, then salt intake about 25%, smoking 4%, and percentage, and beverages 2%, so which makes together 100%. I think something is missing here, but so there we had 100% at the end. For the some of you that are not familiar with the, let's say, a priori algorithm, it is actually the aim is to find rules in the form of, if feature A occurs, then feature B occurs as well. Then we have two measurements which are called support and confidence, as well as lift also, in order to evaluate the rule. So we start with, let's say, one item set, and then we have these items. So you see the items were physical activity, nutritional supplements, salt, smoking, frequency of warm meals, main meals, and vegetables. And we started to with one of them, and then we would gain rules, and then we would evaluate these rules based on our set confidence and support measurements. And the rules that were below this set, let's say, threshold of support and confidence would prune out, and then we would keep these ones that were valid, and then we went to the second item, and we would do that the same for all the, till we have all these 9 item sets together. And you see here the result for these 7 items, and then also the support, as I told you, and the weighted support, for example. Okay, so then at the end we have got some rules, which I'm going to just speak about 2 of these chronic diseases. We are now at the 5th step of the, let's say, our knowledge discovery, which is, let's say, data mining, and the 6th step, which is interpretation. For example, by the blood pressure, the ones that we have calculated that or have medically assessed high blood pressure, they just about 5.1% of the sample. Actually in the whole, it was about, we still have just 0.36% of a sample, which is below 1%, meaning that you can imagine about like 120,000 interviewees, how many less of them have this high blood pressure. Anyway, their behavior was very interesting, because they actually eat 3 times a day regularly. They sometimes eat irregularly hot meal. Then they prepare vegetables more than twice a week. They exercise, because maybe you know that in Switzerland the people do a lot of sports. They exercise a lot. So these people, even though with the medically assessed high blood pressure, exercise 5 to 7 times a week, and then they cook but with salt, or they don't add salt during eating. And also they either smoke, even though they haven't even ever smoked before. So then our our health expert interpreted this rule as this, which says that these rules contain some references to the so-called culinary lovers. This is not a problem if the weight is sufficiently controlled. So in the case of high blood pressure, any weight reduction is helpful in reducing the symptoms. Then by the cholesterol, again, you see again just 1.33% of the whole sample had this confidence of medically assessed high cholesterol, which you see again. They also have a healthy, let's say, pattern. They eat 3 times a day regularly. They also regularly eat hot meals and prepare vegetables, and exercise regularly, and also cook with sauce but don't add sauce, like the one in blood pressure, and also the same smoking habit. And the interpretation is as with the high blood pressure, health awareness is also well developed in diagnosed, let's say, cholesterol, let's say, ill people. So this is shown by the fact that the people do not smoke, in some cases have not smoked before. Because smoking would also seal the vessels even more. So when we see the behavioral patterns is also the same when it comes to the intake of salt and vegetables. These are just 2 examples of the rules. In the paper, you see much more rules also about alcohol and diabetes too. These are these 4 chronic diseases that we have actually took into consideration and find out the rules and also interpretation of them. So the conclusion of our study is that the consumption of alcohol in small quantities doesn't have a negative impact on health when you would see the rules of alcohol. And interestingly, as I told you before, people with medically diagnosed high blood pressure, they do exercise regularly and also take smaller amounts of food. So also these people with the high blood pressure, they probably gain better health awareness because of the diagnosis. And also the smoking habit is either, let's say, mostly the people are non-smoker, or they probably stopped smoking. So these people also eat hot meals more often, which is also an indication of awareness. So these were also interesting findings that we have seen. We have to find out more, which then in the next study we are going to also consider the BMI, let's say body mass index, and other, let's say, criteria into the study to see how this is going to fit into this linking between the food consumption and these chronic diseases. So that was my presentation.